I just wanted to take a moment to provide a general overview of the CTSC for those that are not familiar. So our goal is to improve the health and health equity of people that live in Northern Ohio by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists, as well as community members. So the CTSC is currently doing this by focusing on these 5 key areas and initiatives. So this is resources and services, community engagement, workforce development, clinical and translational funding opportunities, and health informatics. And then I just want to take a brief moment to introduce Dr. Rachel Pope. So she is the Chief for Female Sexual Health at the Urology Institute at University Hospitals. And she also is an Associate Professor at the Urology Institute at UH. Dr. Pope's research is primarily focused on obstetric, fistula, and public health topics that include reproductive health and barriers to women's sexual and reproductive health care. And so I will turn it over to you, Dr. Pope.
Thank you, Mackenzie, and thanks everybody at the CTSC, especially Dr. McComsey. Thanks so much for making this time and having me be here to share this. I'm so happy to see some familiar names pop up here and on the participants list. And really happy to just kind of talk about women's health. So give you a little bit of history lesson today. Hopefully I can teach you some things you haven't heard before and inspire you to continue doing women's health research or start doing women's health research and really generate a conversation around this topic. So it is going to be a little bit of an interactive time. So I do want you to go ahead and in the Zoom link or in the Zoom window, you should be able to shortly see a little pop quiz for some answer choices here. So the quiz is sorry, I think that's on question 3. I don't know if you can go back to the first one. I'll let you do that, Mackenzie. It's what year were women mandated to be included in research by the NIH? And think about it, but your options are 1964, 1980, 1993, or there is no such mandate. Okay, I'm going to test this out to see if this works, but go ahead and put your answers in and hopefully we'll see the results. Mackenzie, do the results just pop up for you or will we all see them?
Yes, they should pop up, I think, and everyone can see them once I end the poll.
Okay. All right. So go ahead and think for just a couple more seconds. See if you can think of this answer, if you've heard about this before. Go ahead and submit, and then I'll give you the answer. All right, so the answer is actually 1993. And I wanted to start the presentation by really illustrating that 1993 was not that long ago, right? Okay, good. 56% of people knew that was the answer. So that's great. But it is kind of unusual that this was such a recent development and such a recent mandate made by the NIH. So I want to take you back a little bit farther than that. So in the 1900s, people widely thought that women really couldn't participate in higher education, couldn't participate in professional work. Why? Because of menstruation. And there's one professor from Harvard, Dr. Edward Clark, who kind of popularized this notion, saying that menstruation diverted blood away from the brain to the uterus. Gosh, like it's very sad, but you could see why people really didn't understand what was going on with women's body. And if you posited a hypothesis of what was happening, people just kind of went along and believed it. So he said that it was dangerous for women to engage in intellectual activity because of this, and that it could cause infertility and it could cause all of these problems for women. So really, to protect women, they shouldn't be involved in these things. And what actually changed the thinking of that time was research. And that's why, research is so important. Thank goodness for Dr. Mary Putnam Jacoby. She was a physician and a professor at that time. And she studied 268 women. She measured their muscle mass. She measured their strength with different activities. She measured cognitive function. She had them answer surveys and questions and looked at all different segments of the menstrual cycle and then time during menstruation, and found that there was no difference in ability based on menstruation. Amazing that a person had to actually prove this, but this had to be proved, right? And that is research. For centuries, there's been this sort of mystery, this cloud of mystery around the female body. People didn't understand how menstruation happened, why it happened, how ovulation happened, how breast milk was produced, and how, what constituted breast milk. And all of these things were seen as sort of mystical. And unfortunately, as time continued to go on and research began to become more developed as we know it today, women were really excluded from participating in research. There was a large concern about the harm to the unborn fetus if the participant were to become pregnant. There was also a belief that the hormonal fluctuations that happen during a menstrual cycle would complicate study results. And there was an assumption that findings from male subjects could basically be generalized to females. There are some, real reasons to be concerned about women of reproductive age participating in certain types of research. So in the 1950s, thalidomide was a common medication for nausea during pregnancy that was used and ended up causing birth defects for up to 20,000 people worldwide. Obviously a big tragedy, and made the FDA realize that actually they needed to look at medications and drugs beyond just a year time period or 2 years. They needed to look at long-term effects, and not just for somebody who was pregnant or a subject, but also of their offspring. Similar, in the 1940s to 1970s, DES was commonly used. This was an estrogen product that was used to try to help women who were having like miscarriages and having a hard time carrying pregnancy to full term. And so this extra estrogen was thought to help support pregnancy. But unfortunately, long-term effects were seen of offspring of women who used DES during pregnancy, specifically clear cell adenocarcinoma, reproductive tract abnormalities, and even subsequent infertility and pregnancy complications. So again, these like long-standing medication outcomes that people weren't really thinking about or aware of at that time. So another quiz for you. When was the FDA formed? 1906, 1960, 1972, or 1980? Go ahead and submit your answers. Okay. Give me just a couple more seconds and I'll tell you the right answer. Okay, so it was a little bit misleading to have this picture of Roosevelt here. The right answer is 1906. So the FDA started in 1906. And the reason it started was because of concerns over food processing and sanitary practices around specifically meat packing. But it continued to evolve, and it was in the 1930s when Roosevelt actually made it a little bit more rigorous, and to really include not only food, but drugs and even cosmetics. And so we see that research began to get even more and more important at that time. Fast forward to the 1980s, people suddenly realized, there's been all this research on medications, there's been all this medical research, but really, most of these drugs have not been tested on women. And then even in animal research, the female specimens are often excluded because of sort of the nuisance or the risks that could happen with menstruation affecting data, with conception affecting data. And unfortunately, we also saw that for many of the medications even for lab results, we don't have really normal reference ranges for women. So in the 1980s and 1986 specifically, the NIH issued a policy to urge grant applications to consider the inclusion of women. They opened an Office of Research on Women's Health to really start to address these inequities. But it wasn't until 1993 that they actually mandated the inclusion of women and minorities in research funded by the NIH. So it was, sort of time coming. You can see how it builds up. And then finally this mandate came in. And if women are to be excluded from a particular trial, then a clear rationale has to be explained for their exclusion. We also saw at this time in the early 1990s increased funds allocated to HIV research as it affects women. And then the National Cancer Institute and Department of Defense started to increase funds for breast cancer research. So what has happened since then? Between 1990s and 2025, there has been a lot of progress. There's been more funding, there's been more research, but we still have major, major gaps in women's health. And this is what I really want to dive into today. We see now that women represent about 50% of participation in NIH-funded clinical trials, so that's much better than zero. But there are some specialties that are still lagging behind, specifically cardiology and nephrology, still really underrepresent women. For pregnancy and lactation, we know that there's ethical reasons that we can't do randomized controlled trials on pregnant women. We see that for a lot of medications and treatments, there's this category C, which is just there's not enough data. And so healthcare professionals are supposed to counsel pregnant women on sort of the theoretical risks and kind of like, well, what's the benefit for you? Is it worth taking this risk? And for a lot of pregnant women, they say, well, if we don't know, we're not going to do something that's going to risk the pregnancy. Now there's this change to pregnancy and lactation labeling rules, and the idea is to look at the risk to the mother, look at the risk to the fetus, and then kind of make decisions from there. But again, there's just lack of data, right? Some ways to fill in that lack of data when you can't do a prospective randomized controlled trial would be maybe, to continue registries, continue retrospective research where people have been using medications or something has occurred not intentionally while a person was pregnant. But still, we saw even with the COVID pandemic that there's new ethical concerns with vaccinations. So whose health was at stake? We really knew that pregnant women who were getting COVID were at high risk for morbidity and mortality, but we didn't know with a vaccine for COVID, how that would affect a fetus or later offspring. And so people were again having to make this decision. Well, are we going to try to protect the woman because we need her to be alive for the fetus to be alive, and we're just going to take a bit of a gamble here? Or how are we going to weigh these options? And again, we kind of see where this lack of data, lack of documentation still affects us today in 2025. Other huge areas within gynecology that we're lacking in information is endometriosis. This is not my area of expertise, but it is a striking one, which is why I wanted to bring it up today. So endometriosis affects about 10% of reproductive age women, but compared to the amount of funding it receives to other disease burdens, it's minimal. To be honest with you, we still don't have a clear understanding of the mechanism of endometriosis. There are different theories and there's different research to support those theories, but just understanding the disease process for something that affects 10% of reproductive age women, I mean, it's kind of crazy that we don't have this information, right? Other areas where we really need more information are the female predominant autoimmune conditions, a huge area. If anybody happens to be a rheumatologist on the call or interested in autoimmune diseases, the one part where this affects my research is I do take care of women with vulvar autoimmune conditions, so lichen sclerosis and lichen planus. There's a few different other ones that are autoimmune and specifically affect the vulva. And so this is some of the research that I've been able to do with the CTSC support, but there's so many more. Sex-based differences in pharmacokinetics and pharmacodynamics is still a huge area that's open for research. And then cardiovascular disease management. So my next pop quiz for you, what is the leading cause of death for women in the US? Breast cancer, skin cancer, or cardiovascular disease? All right, see what they said, Mackenzie. All right, good. 93% of you know that it's cardiovascular disease. So the reason I bring this up is because for many women, they don't necessarily know that cardiovascular disease is the leading killer for them. We see through research, population research and public health research that women are not engaged in preventive health care. They're not engaged in preventive cardiovascular care. However, 80% of women will go get a mammogram in about 2 years or the last 2 years. So we know that there is a society driver or fear probably behind that drive for breast cancer prevention, but we don't see that same driver for cardiovascular disease. And so we have a huge opportunity within the public health world. If anybody is interested in public health research or does that on the call today, to really dive into cardiovascular disease prevention and risk reduction. We know that many heart disease drugs were actually primarily tested on middle-aged men. And ACE inhibitors, beta blockers, statins often had very little female representation in the early trials. And then the intersection between menopause and cardiovascular health is an area of huge unknowns as well. In 2002, the Women's Health Initiative came out and really scared everybody off of estrogen. And at the time, people thought estrogen was protective for the health. And so really everyone should be on it. And then we started to see that older women who hadn't been on estrogen from the time of menopause for at least 10 years, when they then started estrogen, they had increased risks of cardiovascular accidents, strokes, and heart attacks. They saw increased risks of blood clots and other VTE. And so everybody came off of estrogen. At that point, menopause was kind of ignored, I would say, clinically, because there wasn't too much to offer besides non-hormonal medications, which had a lot of side effects. And so then people kind of stopped studying it. There has been a resurgence where people are now really interested in menopause symptoms, menopause management, looking at this window of opportunity. So women who are going through menopause, getting on more hormone therapy in the first 10 years of their symptoms or their first 10 years of menopause specifically, and hoping to find, what would be the potential health benefits if they start hormone therapy early. Researchers are looking at cognitive health, cardiovascular health, and bone health, among others. And I think the overall understanding of menopause affecting every organ system is really starting to resurge. We saw some really amazing researchers in this space. Dr. Naomi Rance in Arizona discovered the mechanism for vasomotor symptoms by studying cadaver brains, where she actually looked through just the pathology of the brains and found hypertrophic areas and was able to kind of work backwards to find what was causing the hypertrophy and figured out the mechanism for vasomotor symptoms. This was in 2015. So again, so much that is happening very recently. Dr. Lisa Mosconi is now demonstrating the changes that are happening during the brain during menopause using MRI technology and finding that there are significant changes and how to actually navigate those changes, what they mean clinically, and translating that to real life patient care is really just at the beginning of starting. So I'm not a graphic designer, but I tried to make a graphic here of the tip of the iceberg, right? So if you think about menopause, endometriosis, all of these other areas of women's health, we are really at the tip of the iceberg. And honestly, it's an exciting time to be a researcher. The field of women's health is wide open. Regardless of what your interest is, there's probably some area that's understudied if it has to do with women's health. We know the intersection for LGBTQ women of minority status, women of color, the intersection of all of these populations, along with all of these health conditions, really still needs so much more research. So I wanted to take any questions. I think there's somebody put something in the chat, and just have the opportunity to engage with all of you, and so we can talk about this topic together. Oh, how early is early when starting hormone replacement therapy? Early is probably perimenopause, actually before menopause starts. So the thought behind the Women's Health Initiative was that the women who were having heart attacks and strokes during that 10 years, from the time that they went through menopause and then started hormones, they were building up cholesterol, building up plaques and lipids. And then they started the hormones, which probably catalyzed those events. And so early in that sense is within 10 years of menopause, and menopause being defined as 12 months of no periods. But in my clinical practice, I have a lot of women who are going through perimenopause, meaning they're still having periods, but they're starting to have symptoms of menopause, and they're in their early to mid 40s, because that's about 10 years before menopause, that perimenopause can start. And so for many of them, they are starting hormone therapy even at that time. And theoretically, that should be the safest time to start hormones. I have another question here. Is HRT recommended for all women or just those with bothersome symptoms? This is a great question, and something that I feel like those of us who are in the menopause research space are trying to get an answer to, and it's not super clear. It's so individualized based on what people's medical risks are, what their risks are to be on hormones. But if you are medically eligible for hormones and you have one or two symptoms, it's going to be more effective than having two medications that are trying to treat each of those symptoms. Now, I have some patients who don't have very bothersome symptoms, and they've asked me, should I be taking this as a preventive? We don't really have the research to say, yes, everybody should be on this as preventive at this point. But it does look like, from the cardiovascular research, from the cognitive health research, especially what Dr. Mosconi is doing, it does look like there may be some signs pointing in that direction, that it could be very protective. We know it's protective for bone health. So if you're a person who's at very high risk for osteoporosis, or if you have a strong family history for osteoporosis, then we do know for sure estrogen would be protective for that, even if you don't have other symptoms. So it's very individualized. I recommend everyone speak to their healthcare provider. But hopefully that answers a bit of your question. And it looks like Ray, you have your hands up.
Yeah, thanks for walking us through all that history. I really appreciated it. A question that I had, you mentioned that in a lot of the pivotal studies for like the cardiovascular drugs, the studies were done entirely on men. I guess I was just wondering, like, are companies, are researchers like going back and doing like are they going back and redoing those trials? Are they at a scale that's comparable to the initial trials? Like how do we what is going on to sort of like
Yeah.
address that?
No, it's a great question. Some companies are, and I do see some work going in that direction, but not all are. Like, then there's no clear mandate or even push really to do that. I haven't looked, recently at clinicaltrials.gov, but I think there are some trials that are going back. And then again, like recruiting women and trying to figure out how to I guess, compromise with including reproductive age women. I see most trials really just recommend that people are on contraceptives now. So I've seen that in the last like 5 to 10 years, a lot of drug studies just requiring contraceptive being used at the same time. So I think that's part of the effort, but yeah, I don't think it's happening everywhere there's a lot of medications out there. And there's a question here from Laura. If you're a predetermined increased risk for breast cancer, should you entertain the idea of HRT? I would talk to your healthcare provider about it. For a lot of women, breast cancer obviously is a concern, and we know that with increased estrogen exposure, there's increased risk of breast cancer. But a lot of the research that had demonstrate sort of higher risks of breast cancer exposure, or risks of breast cancer based on exposure, are based on equine estrogen, conjugated equine estrogen, which is coming from horses. And we have changed sort of the estrogen options, and we're hoping now to see more large studies that will look at breast cancer long-term effects using the estrogens that we're using now that seem to be much safer, and also the progesterone. So if you still have a uterus and you're using estrogen for hormone therapy, you have to have progesterone to protect your uterus from estrogen exposure, and not all progesterones are created equally. So the micronized progesterone is what has the safest profile for breast cancer risk. And so It's very nuanced, as you can tell, but if you do not have a personal risk of breast cancer yourself, you might want to talk, but you have a strong family history, you might want to talk to a genetic counselor and see if they can give you some more ideas of your personal risk, or see if what you could do to make things as safe as possible. And so it looks like Dr. McComsey has her hand raised.
Yeah, I was going to comment on one thing since
Yeah.
this is Science Cafe, right? Not didactic.
Yeah.
Your first question about the mandate to enroll women, I put actually there is no mandate because to me, if you enroll one woman, you qualify as you did your job. And this is unfortunate because
I didn't know that.
right? Like Ray said, actually asked the question, all the data was from men. So because, it's very hard to have women, they have kids, responsibilities. So it's always like the easy way. Don't enroll women in study. It's hard. They drop out. So
Yeah.
we ended up with tons of data on men. And then when we started to do some smaller studies that are female only, because we recognize that having 5% women is a joke for a drug to say it's approved in women. We started to see a lot of adverse events. So yes, it was effective like in men,
Yeah.
but as Rachel, you mentioned, PK studies were lacking. Like we only have PK studies in women during pregnancy. But beside pregnancy, like most of their life, they're taking those drugs. We don't even know, are we overdosing them? Is that why they are having a lot of adverse event and intolerance? And it's sad that drug companies, they want the drug to be approved, right?
Yeah.
So there's not that extra step. Like if I'm the FDA person, I would say this mandate is a joke. You enroll one woman, you're good. It has to be either women-specific studies or at least a minimum proportion of women on the studies to be able to see if there are sex differences
Yeah.
in tolerance, in adverse event, as well as efficacy. So I think it is sad that, back in 2025, and that data is still not there. And this mandate is a joke. You have to mandate either specific studies to women or at least certain proportion of people on the studies being women.
Yeah. Oh, thanks for that. Yeah, that's so interesting. And it is upsetting. I think you kind of are answering the question that Serene put here about cardiology and nephrology and reason why. And I think that's probably the same for those fields. And interesting, I've spoken to a few people who do animal research, and they've told me that basically it is really complicated to have animals that are potentially going to conceive while they're doing the studies or have some estrus that really affects even their temperature and all of everything. And so for that fact, they're like, well, we're just going to use male mice or male animals. And so then I asked somebody who was working on developing some animal models that are specifically for female sexual function, right? Because you can't exclude females. This is going to be for females. And they said it's again really tricky to then look at premenopausal versus postmenopausal, because it's easier for them to just remove the ovaries from the mice, and then that's how they study. So then they're theoretically just doing postmenopausal research on animals. But then they told me they can't really mimic menopause in the animals that they've removed the ovaries from. So there are 2 FDA approved medications for low desire for women. So as Mackenzie mentioned, my clinical practice is female sexual health. And those 2 medications are only approved for premenopausal women because the FDA told the researchers focus on premenopausal women for these 2 medications. I don't know the reason behind that. They just thought it was more simple or what they thought it was. But the animal models don't match up. It's very confusing. And then you look at the data of women who are having issues with desire. Well, it peaks in the population around menopause because of the decreased testosterone. So all of my menopausal patients who are coming in to talk to me about low desire, I have to tell them, sadly, the 2 FDA approved drugs for desire are not approved for women post-menopause. And so it's like, I hate to say it, it's kind of a joke, right? Like, why do women have to be separated based on premenopause or menopause when they're being evaluated for medications that are for women? And then, I guess the cost of just doing the trials makes it so much that the companies that are producing these drugs really are going to do what they feel like the FDA is going to approve or not approve. And so if they tell them focus on premenopausal women, that's what they're going to do. And yeah.
I mean, I think now there are FDA mandates for pediatric studies, right, for drugs. It's a shame that there are no females, mandated studies for females, because
Yeah.
it's a joke. I mean, women
Yeah.
are different than men,
Yeah. Exactly. I would love to hear from people on the call, like what the fields that you're coming from and what you've seen in your work. If you see that there's areas where women's health is or research is lacking, or if you have positive stories to uplift us.
I can start. I encourage people to talk.
Yeah, that'd be great.
So, I do HIV work at that comment of that, but
Yeah.
I also do long COVID work, right? So I have a lot of funding in long COVID, and this is an area where it's vastly women. Men can have long COVID, but it's majority women.
Okay.
And our data from this side showed that women after COVID get a very significant arterial stiffness. We did it in 3 different cohorts, and it is amazing the difference
Wow.
between men and women. And that puts them at risk for heart disease, for hypertension. As you know, I mean, the numbers are like ridiculously different. We published that, and I can tell you that people are taking the observation of arterial stiffness and worrying about it. Nobody is commenting on the sex differences. It's like people, I mean, we publish it again. We looked at why are we seeing the stiffness difference, and there were a lot of differences in gut dysfunction. The gut has a lot to do with cardiovascular disease and inflammation. A lot of inflammation differences. I mean, women have like ridiculous immune activation after COVID. And I can tell you, as much as people talk about our arterial stiffness, nobody comments or care about the sex differences. And that drives me nuts, actually, because it is clear. And they asked us to duplicate it. So we did different cohorts, as I said, and the results are the same.
Wow.
And they said, oh, maybe it's something to do with the machine. I'm like, okay, it's the same machine that we're using on men and women with the same technicians doing the work. Like, can it be like a worse, comment? And it's very frustrating, actually, when you're a woman working on research.
Yeah.
Seeing this, differential treatment.
Yeah.
If it was the other way around, I mean, with all due respect to the men here, but
Yeah.
the other way around, it would have been like all over the news. Man, they're gonna drop that from heart disease. But even though women get a lot of cardiovascular disease anyway, that finding doesn't seem to resonate with the vast majority of people, and that you can tell frustrates me like crazy.
Yeah. My goodness. Can't even, I'm so curious about what the mechanism is or what is happening. And obviously the clinical outcomes of that would be drastically different.
Yeah, absolutely. I mean, all of us got COVID by now. So, and it's not even linked to having symptoms. So a lot of these women have like totally, they're asymptomatic. They thought that COVID did nothing. Yeah, I got sick. Now I'm fine. And we still see large differences.
Wow.
So.
And those are the changes that we see with menopause too, right? With the lack of estrogen, the vessels become less compliant, they become more stiff. And another interesting sort of like history point is back when people thought estrogen was the answer for everyone, they even were giving men estrogen to see if that would help protect them cardiovascular wise. But then they were kind of getting like breast enlargement. And so people went off that pretty fast.
Actually,
Go ahead.
funny, actually. But you mentioned menopause. Yeah, I forgot to say that they said, oh, probably your women are all menopausal. Well,
Oh, no,
luckily
they're not.
we have that data, and there were very few. Most of them were in their 30s and early 40s. So this is not a menopause.
Yeah, it's not the reason why.
Same, like the guy you showed with the menstruation, the silly comment. It's always like silly comments. It's always a woman thing that caused that. That's why it gets ignored, and I think
Yeah.
it's so not fair to half of the population is women.
Yeah. We need more women like you doing the research, right? Because you could also see how the interpretation of the data could have been different if you weren't the PI there, right? And so that's another point. Rini, go ahead.
I don't have a research story, but I just wanted to share the name of a book I'm reading right now, which is entirely in alignment with this topic. It's called Inferior: How Science Got Women Wrong and the New Research That's Rewriting the Story by Angela Saini. I'll put it in the chat. It's basically just about this kind of stuff, how historically science has been conducted by not women, and how it's women's bodies and how brains and everything has been misunderstood and still being misunderstood, and how women are changing that landscape.
Wow, thank you. That sounds like a really good book. The other thing I was kind of curious about, I'd love to hear from the group is, the CTSC is full of resources to help people do research and to kind of even get started if you haven't done much research before, or to facilitate if you already have. And I just thought, what is something from the group that could be helpful that the CTSC could help with for one, doing more research for women, but even getting women involved in research. I'd love to hear if people have any ideas. And I know it's the lunch hour. If you need to be eating while you talk, feel free to.
Hi, I have a question, or I
Sure.
guess a comment. I'm Cassandra. I work at a Cleveland Clinic in the clinical research unit, and I know we often talk about, if you have people representative of a community, it's easier to get more people to do it. So being in research, and majority of coordinators are women. Why do you think it's hard to get women to do research if you have huge representation of women? Or is it just about the PIs who's not doing this study, or what?
That's what I want. That was my first thought because the PI is designing the study, but I don't know. I mean, it's the research coordinator is the face of the study in a lot of ways. What do you all think?
Yeah, I think it's a tough question. It's a good question, Cassandra. It's, like when we talk about enrollment of, underrepresented minorities in research, I think for one, as the PI of a lot of studies in the last 20 years, it is harder for women to commit to a study. Not because they don't trust the PI, not because they don't care about the research, but we all know, regardless, if our husband or partner is really supportive, right? It is harder. They have more responsibilities. So most of the women see research as, yeah, it's great. What worked in my clinic, the HIV clinic, is to remind these women that the problem that we have in HIV is we're giving women probably the wrong dose. Women are getting more adverse events. Studies do not have women, like make them see, like we do with other populations, the importance of being represented in research. I think when I talk to them that way, even though it's still, a number of them will say, I just can't. Like, yeah, I agree with you. It would be nice if I can, but I have so much on my plate. I can't add this.
Yeah.
I think some of them start understanding that, yeah, you're right. I want drugs. I want to know what I'm taking. I want studies to be done in women. So Cassandra, I think like every other population that we talk about, that we don't enroll enough in research, we have to understand their challenges, and education is important. Like, make them understand why it is important. You don't want a study that's 90% men, and then you take that drug. So I think a lot of education is needed, but understanding that that population has a lot to deal with, much more than men. So a lot of time, even though they want to, they just can't. So sometimes we take the mobile unit to where women, like when we had women on studies and they said, I can't come to you, or say, okay, we'll give you a lift. We're willing to pay for a lift to bring you for research. And they say that's, if they live far, that's too much. My kids, I can't leave my kids. So we try to do what we can. We try to go there. We say, get your kids on the mobile unit. It's fine. They can just wait with you. Like, you have to do extra steps to enroll women in studies. You have to understand the challenge and try to help. And that's what we do in the CTSC. We try to help recruitment, education about the importance of research, but also steps like the mobile unit, transportation, and other things to try to help them so they can make it to research. It's tough. I mean, it's not easy, but the attitude like the FDA is taken, that it's okay, just enroll a few women, you're right. That is very,
Check the box.
you can tell
Yeah.
that's a pet peeve of mine, because you can't do that to half of the world population, to say you just have to follow the other half, even though we don't know much about you, but you'll be fine. I think that's so like old, and we have to change that.
Thank you.
And I think another thing, just wanted to add, I think it comes down to resources. A lot of it comes down to resources in terms of when you're designing trials. You have these eligibility criteria. I was working in IBD and we were trying to develop just a non-invasive test. And we had, part of the exclusion were, breastfeeding women as well as, women, but we ended up actually, reversing that to help with enrollment. But I think it's important also, to have like, within, maybe some type of a subcommittees, within institutions. So they're reviewing these trials as they're being designed and kind of giving, that, the idea of it, that, having a little sub-study, maybe, trying to simultaneously do these studies, where, if it's not invasive, I think it's a little bit easier to include women. But if it's, something that, it's not approved yet, I think it makes it a little bit more challenging. But, having maybe, subcommittees within institutions that, could review the trials and kind of provide that feedback, where, women can be included, maybe it can facilitate more, inclusion of women and, different, to add to it and do small feasibility studies. But again, how do you kind of bypass the challenge of resources when you have like a certain, amount of funds for certain? And I wonder if, CTSC has, something like that, within the umbrella of, is it doing something with a women's initiative, to kind of alleviate, that part and include more women to research? I don't know if, anyone is aware of anything.
So we're funding a lot of, women's studies, like women-specific studies as well. But you're right, actually, what we can do is to think about funding or focusing on some studies that are enrolling overall, and maybe seeing if we can do a sub-study, how can we increase enrollment and recruitment of women, and try different strategies within the larger study to see if we can do that. Because just saying, we need to do it, I mean, obviously it's not enough, right? So we have to do something. So yeah, that's a great idea. We can talk about it. Thank you.
Thank you.
Ray, you have your hand up.
So I'm part of the Brubaker Lab in the Case School of Medicine, and our research focuses on the microbiome and its impacts on women's health, sort of specifically the vaginal microbiome and how that interacts with endometriosis, cancer outcomes, things like that.
Oh.
And so we're perhaps a little bit different because we're a almost purely computational lab, right? We do math on data, and so we rely on public data for what we do, but particularly when it comes to the vaginal microbiome and the things we need, there's just not that much of it. So one of the things we're looking at doing right now is partnering with some of the like commercial companies that do vaginal swabs or characterization, and seeing if we can improve our models so that we can use what they have, because they have more than most people do. So that's something that we're working on.
That's very cool. I do think that there is a change as more people become aware of sort of the lack of information. And I mean, we're seeing that in the menopause space, that women are becoming stronger advocates for themselves, and that's shifting the medical community. And so I think that that will translate to the research as well, to encourage more and have more expectations in that way. But you're right, like the resource allocation has to match that too. Maybe that'll come also from the private sector as there's more demands for filling those needs.
You have a question, Dr. Messer?
Oh, yeah, sorry, I didn't see your hand up. Go ahead, Amanda, Dr. Messer.
Oh, that's okay. Thank you. So to, excuse me, go back to my colleague Cassandra's point, Cleveland Clinic project manager as well. So going back to why don't we see more women participating as well? So I believe too, we do a lot of recruiting as part of our jobs, and when you come into a place where the research is done and you don't see many people who look like you don't feel comfortable, and word gets around, things like that. So if you don't see many women scientists or professionals there, the managers and other things like that, then you kind of feel like sheep being led to the slaughter. So you see the women faces at the health fairs and the tables, but then when you go to the place of, science and research, and you don't see, the women there, then it's like, okay.
Yeah,
So,
trust, right? It's about
yeah,
trust.
so it goes back to, pumping more women into the pipeline. But, unfortunately, these days we don't know what we can do in regards to that, if that's, considered something bad now to do that. So those are just my comments on that. And then, encouraging more women and other minorities to get into research, because I myself was looking to get back into that field, doing more research, different type of research from what I did before. But again, with the current climate, would I get funded? Would I, I don't know. So, so
I
those.
can give you a little bit of an optimistic story. I have a good friend who does breast cancer prevention and treatment research for women, like internationally. And she wasn't quite sure what was going to happen with the current climate, and she got her K award to do research for the next 3 years. So I feel like I've had the same thoughts. Is it worth even putting applications in? But things are still getting funded, thank goodness. So And you know, she's doing global research affecting underserved areas. So don't lose hope.
Don't lose hope, Amanda. Hey, I got one. I guess I should be on video like everyone else.
It's okay.
But my oh, I think my cover off. But my other question was, or I guess comment, if cardiovascular disease is the #1 killer of women, how do we let women know that? Because women, I feel like we do studies for women's health all the time. You know, if it's about breast cancer, we had so many women want to do a breast cancer vaccine, we had to like pause because it was like, I'll donate the blood, you know, because everybody's been affected by it. But like, how do you get the word out that, you know, it's bigger than breast cancer and those type of, because a lot of women don't know that. And I mean,
Yeah.
even like people in
It's a,
research.
oh, sorry. I didn't mean to interrupt you.
Oh no, that's fine. I just want to know how do we say that? Because literally we do a lot of OB studies. We don't have a problem recruiting women for
Right.
those type of, they feel like it's a woman thing. But anything that's like, you know, some of the kidney studies is, but like anything else is like you have a hard time convincing women it matters to them.
Yeah, and I think that's the hard thing with cardiovascular disease because, you know, even hypertension is like the silent killer, right? And so you don't feel the symptoms as much. And also things are more chronic and long standing. So it takes a while for someone to really get so sick from a cardiovascular situation, unless it's a stroke or a heart attack, you know, immediately that affects somebody. And so there's almost a different response, I think, culturally for us in the US, where people, they know breast cancer and they know cancer in general and how awful that can make someone feel, how the treatment can make someone feel. And it's like the cardiovascular risk is just kind of like silently out there without people recognizing it, and without it being treated. So it's an area, as a gynecologist, I'm becoming more and more interested in it because I see this window of opportunity to try to optimize women's cardiovascular health, where it overlaps with menopause care, and then also where sometimes people can't be on menopause treatment because their cardiovascular risk is already too high. And so trying to find how to reduce people's risk to get them treatment for menopause symptoms, but also potentially benefit their cardiovascular risk overall, is an area that I'm really interested in. But my theory is that it's that silent killer, and we don't have like as much of there is a heart disease awareness month. I can't even tell you which month it is, but I think there is one. There is one compared to like breast cancer awareness, where we've got parades and pink ribbons, and like it's just a much larger campaign. Go ahead, Elise.
Hi, thanks. This was a great presentation and a great conversation. I just want to say I think it was Amanda who was asking that question. How we get the word out, or maybe it was Rainy. I'm not sure who it was. Anyway, we do a lot of work in this area, not necessarily in menopause, but in cardiovascular research. And I work with Dr. Sherry Bolin, and we do a lot of dissemination and implementation work. And I've actually been thinking a lot about this specifically in terms of menopause and symptoms and all of the things that affect women. And what I really would like to do is work with you, Rachel, and design like a statewide dissemination program that gets at the providers and the patients. And we've had a lot of success with that in cardiovascular disease, specifically around hypertension and diabetes. So I think that would be a way to go about it. Like, we know where the evidence is, especially around HRT. And I think there's so many people who are, you know, even my friends, you know, which is like our targeted demographic area, you know, they're like, I can't go on HRT, you know, and I explained to them like 30% reduction in all-cause mortality. It can help with, you know, osteoporosis. And they're like, well, why isn't my doctor telling me that? And I'm like, because your doctor has to check your blood pressure and ask you about, you know, are you safe at home, and all of these other things that primary care providers have to do. So we really need a targeted intervention directed, you know, at the providers, but also at the patients and their families. And then who do they talk to? So like for one of our interventions, we've incorporated a barber's network. So I was like, what if we incorporated like hairdressers, you know, like, because
That's cool.
you tell like, I mean, I tell my hairdresser, like, I mean, the things you tell your hairdresser, it's like, you probably don't tell lots of other people, right? Because they don't
Yeah.
care what you really say, you know, it's like, it's not gonna go anywhere. It's just, so I think there's a number of ways to go about it. And I kind of started drafting like a specific aims page around it. But
Cool.
yeah, I had reached out to you about it before, Rachel, on LinkedIn.
Oh,
Yeah.
did I miss something?
No, you said you were busy, so
Oh, I'm so sorry.
it's okay.
No, but probably because it wasn't on my
Yeah.
radar as much, because right now what I'm trying to do is design a study where we approach women who are waiting for mammograms, and we have them like have this cardiovascular sort of assessment that's done right then and there, and then we're trying to figure out,
Mhm.
okay, what do we do next with that information? But because of women going in for mammography so regularly, I'm trying to sort of figure out, kind of engage them there rather than in their doctor's office. So anyway, I would love to loop up with you
Yeah.
about that. I'm sorry if I
That's okay.
missed
We're all
a
busy, you
previous
know,
time.
especially it's very hard to write grants now with the word woman in it, so.
Yes, yeah. It's true. It's true. But I hope that you guys do also keep writing the grants and see the need for all of this research. I mean, each person who's part of the conversation today, I feel like your work is important and your perspective is valuable. And we all have to kind of be there to show up and do this work. And whether whether you're out there recruiting participants or you're designing the study, I'm just really glad that you all took the time today to be here and talk about this. And I want to encourage you all to keep doing the good work for women's health.
So Rachel, if I can say one thing,
Absolutely.
I think Elise said the comment. I think you're absolutely correct. Primary care providers think way more about cardiovascular disease in men versus women. There's no question about that. So we need to get not only to the women to understand that they're at risk, but those primary care providers. You're absolutely correct.
I would also add like families, like, you know, I think, you know, when we talk about menopause now, it's not like a secret conversation anymore. Like, I think my husband currently knows more about menopause than he ever wished he'd have to know. But, you know, it's also like, you know, I am of a certain age and I'm also like interested in it from a research perspective. In fact, I've renamed my dogs because we have 3 of them instead of like, he calls it the wolf pack. I call them the many paws.
That's awesome.
So, yeah.
That's awesome.
I think it's like, you know, I think there's a lot of work being done to normalize the conversation, but we still have a long way to go.
Yeah, 100%.
Perfect way to end this. Good joke. All right, so Mackenzie, you want to close it? Thank you, Rachel. Again.
Yeah, thank you. Thank you all
you.
for being here. I really appreciate your time.
We appreciate your time and your work. And like I
Oh.
told you, don't let anybody tell you your work's not important.
Thank you. I appreciate it.
Yeah, thank you so much, Rachel. This was a really great session. So there was really good discussion. So I just wanted to take the last minute to throw up a few QR codes. So the left QR code is so that you can register for next month's Science Cafe, and this is on bionutrition with Alicia Thomas, and that's on May 8th at noon. The middle is to provide feedback from this session, and there's also an area where you could suggest a future topic. So if you know of a content expert or just a topic in general that you'd like to suggest, you can put that there. And then of course, this is the QR code to become a member of the CTSC if you are not already. And then, yes, I just see some praise in the chat. And then if there's any final comments, questions before we close. Otherwise, thank you all and enjoy the rest of your day.
Thank you. Have a good day.